Alright, hello and welcome to the Internal Medicine series for clinical clerkships. Today we'll be discussing acid-base disorders, specifically non-anion gap metabolic acidosis, which we'll refer to as NAGMA. So, NAGMA is essentially defined as a metabolic acidosis with a normal anion gap. Okay, so how do we calculate an anion gap? Let's talk about the basics first. So, an anion gap is essentially the sodium, right, minus the chloride minus the bicarb. And this is a normal limit will be between 8 and 16 for the most part. That varies a little bit, but it's usually between 8 and 16. We call that a normal anion gap. Okay, so let's look at how this is able to occur despite a metabolic acidosis. It all comes down to the central hallmark mechanism of this anion exchange protein, which allows an equal molar amount of bicarb to be exchanged for chloride. So let's assume that this is the kidney that we're in. We're in the the type B intercalated cells, and this is the lumen within the collecting duct, and this is intracellular. Let's just call it IC. Okay, and what happens here? Let's say that under some state, for some reason we're losing a lot of bicarb here, right? Either we're gaining a proton or we're losing a bicarb. We're really going to call it the same thing. So a bicarb is being lost. Right? You would expect that if a bicarb is being lost, this will decrease. That should really increase the anion gap, right? However, if an equal molar amount of chloride is being driven into the cell through the help of this helpful anion exchange protein, then you will see that despite the fact that the bicarb is going down, the chloride is going up in an equal molar amount. Thus, we have the preservation of a normal anion gap despite having a state of metabolic acidosis. So, bottom line, bicarb that is lost is replaced by the chloride. And that is really the hallmark mechanism of how an anion gap is being able to be normal despite having a acidotic state within the body. So once again, imagine that this is the serum electrolytes within our body. We have the sodium, we have the chloride, we have the bicarb, and we have some unmeasured anions right here. So normally, remember what we said before, the sodium minus the chloride minus the bicarb, right? That will give us the anion gap. Now let's say that for some reason the body is in an acidotic state, right? And by that we mean the bicarb has decreased. You see this? It has decreased by about this much, okay? However, in this case, look what happens to the chloride. It's compensating this amount that has been decreased. So when we look at the anion gap again, right? He is equal to Na minus Cl minus bicarb. You see that although the bicarb has indeed gone down, the chloride has compensated by going up for an equal amount, so the anion gap is preserved despite this being a metabolic acidosis. So how does this really happen? What are the causes of a NAGMA, right? So really the way I'm thinking about it is, I try to break it down very simply, is thinking about GI losses as the first cause, renal losses, and third, really a subset of renal losses is drugs, specifically carbonic anhydrase inhibitors. So let's break things down first. Let's look at it from the GI point of view. So the most common causes would include diarrhea, fistulas, and ostomies. And in all three of these cases, you would have a bicarbonate loss, right? And let's remember this helpful anion exchange protein is going to play a huge role in maintaining a normal anion gap despite the fact that we are losing bicarb. So let's look at what's happening here. So let's say that for some reason we're having the diarrhea right here, right? And the bicarb is being lost. Now normally you would expect that the anion gap should increase if the serum bicarb will be decreased. However, it is maintained. And how is it maintained? So let's look over here. A very similar helpful anion exchange protein, right, AE1, it's right here, exists in the luminal border of the intestines. So even though we're losing a lot of bicarb, we're gaining an equal molar amount of chloride. And that chloride is very helpful in preserving the anion gap. So in the end, we have a normal anion gap. So despite the fact that, let's say we have a diarrhea, right? Or we have like an ostomy or a fistula, we're losing a lot of bicarb, the chloride is able to be maintained. And in that way, the anion gap will be normal, right? And similarly, in GU losses in drugs, let's look at it from the renal standpoint, right? So let's, for instance, the most common causes would be RTA, renal tubular acidosis, and acetazolamide, carbonic anhydrase inhibitor. Excuse the poor writing here, I'm writing with a mouse. So in these two cases, look what happens. Essentially, the bottom line is that the bicarb is being lost, right? So I know in renal tubular acidosis, sometimes we're saying that, okay, a proton is unable to be excreted, but really in the end, if it's unable to be excreted, we can just say the same thing, that a bicarb is being lost. So they're really the same things. And for carbonic anhydrase inhibitors, it's inhibiting this step that's not shown here, but essentially what happens is you are unable to reabsorb the end bicarbonate. So look what happens here. The bicarbonate will leave and it will get excreted in the urine. And we expect that the serum bicarb will go down, right? However, once again, this should not affect our anion gap because look what happens here. This helpful AE exchanger protein, once again, helps to drive in the chloride, right? So in the end, even though we're losing one bicarb, let's say an equal molar amount of bicarb, we're also gaining an equal molar amount of chloride. And thus, it is in this mechanism that despite the body is in a metabolic acidosis because we're losing the bicarb, right? That's why we have the metabolic acidosis. The anion gap is actually preserved because another anion is actually helping to keep that gap. It's helping to bridge that gap, and in this case, it's the chloride. And remember, in all three of these cases, in the GI and the GU and also the drugs, the hallmark mechanism is the anion exchanger protein, which helps to exchange the lost bicarb for a gained equal molar amount of chloride. Right, so there's one more way that we actually didn't talk about, and that's called gaining a chloride, right? So far we've talked about losing bicarb, creating a nagma, but there's one more possibility that's very common on the clinical clerkships that you will encounter, and that's actually due to gaining of chloride. So if we look at this similar picture, now we're presenting it in a different way. Before we were talking about the losing of bicarb and that being compensated by, remember, our helpful chloride bicarb exchanger. Now instead imagine that for some reason the bicarb is still going down, yes, but the chloride is increasing on an independent reason, right? So let's imagine the scenario where a patient who is perhaps in the medical ICU has sustained perhaps intubation and severe metabolic acidosis, is very dehydrated, is getting some 0.9% sodium chloride, right? So remember what happens when we add sodium chloride to our body. This is something that we don't typically think about very often, but look what happens when you add sodium chloride that reacts with the water in your body. It forms HCl, and this is obviously very acidic, right? It's pKa. It's probably somewhere around 2 or maybe even lower than that. So let's consider the scenario that a patient gets a lot of NaCl, right? Basically what happens is you're going to be producing a lot of HCl, and that is going to drive down the patient's pH. It's going to decrease the bicarb, okay? But interestingly enough, it's going to increase your chloride. So this is another independent scenario in which you could have a nagma, right? Because your bicarb is low, your Cl is high, and you have a metabolic acidosis with a normal anion gap. Because remember, the bicarb and the chloride are basically compensating for each other. So let's talk about why this is so severe in a patient that gets a lot of sodium chloride, right? So normally in our bodies, we have about 140 milliequivalents of sodium, and we have about 100 milliequivalents of chloride, correct? If you review what happens in the IV fluids, this actually contains about 154 milliequivalents of sodium, and it contains similarly 154 milliequivalents of chloride. So as you can imagine, if you're adding equal molar amounts of Na and Cl into our body, right, through this IV fluid, you'll notice that the sodium is actually quite similar to the normal physiologic sodium concentration in the body. The osmolality is 140 versus 154. However, you'll see that the chloride is much different. And this is actually very important because when you're adding sodium chloride into the body, you actually will preferentially increase the chloride, aka the chloride will be affected to a much greater degree than the sodium will be. And if we come back to this picture, you can now see that the chloride is actually increasing independent of the bicarb. And the bicarb is going down for a different reason. This time it's going down because H+ is increasing because we are creating HCl. So this is very important. So don't only remember that, there's GU losses, there's GI losses, there's also the drugs, carbonic anhydrase inhibitors, right? So those are all talking about the loss of bicarb. But remember, based on this anion exchange protein, if we increase the chloride, a NAGMA may similarly present. So this is a very important thing to remember on the Clerkships. So really remember that in this case, if you're giving large boluses of sodium chloride, for instance, to a patient, you will induce a hyperchloremic, right? Why is it hyperchloremic? Well, because as we mentioned before, chloride in the intravenous fluids is much higher than the normal osmolar chlorides in your body. A hyperchloremic, hypokalemic, and why is there hypokalemia? Well, it's because sodium chloride doesn't contain any K by itself, right? So what you're really doing is you're increasing the presence of other ions and also, of course, free water. So obviously you will expect the K to be decreasing, right? So you're creating a hyperchloremic, hypokalemic metabolic acidosis. And always remember this when you're on the wards and you see a patient who has this type of presentation and this type of electrolyte abnormality in the labs. Always consider perhaps they had too many boluses of intravenous fluids.